To first of all look at what's happening in international health, with some brief examples of what's happening in relation to global epidemiology, then drill down to a few country examples, really to give details of what Nigel and Sir Eldred have said, then look at a couple of organization level innovations that we need to learn from, that we need to apply, and we are trying to learn from. So what's happening in global health? Well, interesting times, because if we look at some of the major killers, and again, the diseases I've selected are not exhaustive. So this is HIV/AIDS. You can see now there's actually a decline in terms of the new HIV infections are going down, and the mortality rate from AIDS is actually heading south quite dramatically. If you look at this is a paper from the Bulletin of WHO published late last year, you can see a decline in TB mortality. This is in TB in the HIV negative population, but also in HIV positive population. But clearly, big problems with those individuals affected by HIV. But there's a downward trend. But the trend is not as dramatic as HIV or AIDS, as you've seen. Real success story is malaria, and this is a slide from Chris Murray at Institute for Health Metrics and Evaluation. After really a disastrous increase in the number of malaria cases, which shows us that we really need to sustain investment in health systems globally, otherwise we'll have rebound. There's been a massive increase. Now we can see a decline in deaths globally. And what's interesting about this slide is that deaths are not just in under fives, but a large proportion of the deaths are actually in individuals, in adults. Almost 700,000 deaths were in adults, according to Chris Murray's estimates. Maternal mortality, again, one of the difficult areas, and I think Nigel's been leading a global effort on this over the last 3 years. Compared to other figures, you can see the decline, almost like tuberculosis, fairly flat. We're not seeing the big changes as we've seen with AIDS and malaria, so much more needs to be done for maternal mortality. Every single maternal death is preventable. We should be able to see a massive decline, but why is this not happening? Because it's not just hospital-based care that we need to focus on. It's about educating girls, it's about educating men, it's about income, access to care. This is a multifactorial, multifaceted problem, providing oxytocin, so on and so forth. But all the elements need to be in place before we can see a big decline. But there are major global efforts in this regard. But there are issues. As you can see, this is, you don't need to worry about the colorful bars. We'll make the slides available to you. But I want to show you sort of 3 phases of investment in global health from external sources. There's been a steady increase up to 2000. But between 2002 to 2009, there's been a massive increase. You can see a big change in the trajectory. And that is because of the Global Fund and also the Gavi Alliance and other both bilateral and multilateral sources. But what we're seeing is a flattening of external financing. So there's a big danger, as you've seen with malaria, that there will be the gains that we have managed to capture are not going to be sustained, and the epidemiology may change. So we need to do 2 things. First of all, we need to try and see if we can find new monies, either from external or domestic sources. But if the amount of funding is not going to increase, what can we do? We're all very bright students. Probably more IQ in this room than a small country. So what can we do? Let's see who is awake. Someone in the front. So the money is the same. We need to sustain the gains.
Sustain the gains,
or continue improvement. What do we need to do?
Make your use of it.
Exactly. So we need to look for more efficient and effective ways of doing business. So I think Nigel alluded to this. So we need to really focus on relentless innovation at country level, at every stage of care delivery and also in public health. We need to do this also because, not because external financing is flattening, and many countries have experienced flattening of their GDP growth. There are also concerns around aid effectiveness, which is affecting the electorate, which in turn is affecting the politicians in power. And there's a big debate going on globally whether there should be an increased amount of financing going into aid and health-related overseas development. And there are a number of books. I don't know if you've read any of these, but they're all interesting books that have a particular view. But you need to take each one with a pinch of salt. Now, I look very carefully regarding hard evidence of experience from Africa in relation to quality improvement. And it's very interesting. I know that there are many, many, many initiatives, but there are very few published papers in academic journals, what I would call robust evaluations. But there are a number of institutions doing interesting work. So there is the Institute of Healthcare Improvement, for example, has got programs in Ghana, in Malawi, in South Africa. But a recent review undertaken by African researchers show that there are very few quality improvement articles from sub-Saharan Africa, and they're difficult to locate in the standard databases that you may search. And secondly, even if these studies are available, there is no central repository for them. So you'll need to actually know the kind of people, like Sir Eldred called somebody in Lusaka or called somebody in Malawi to try and give examples of what's happening. So there's a lot happening out there, but we're not able to capture these. But I want to share with you some examples at country level from Global Fund Finance programs. First example is the Gambia. Global Fund financing is provided in rounds. They're called round 3, round 6, we went up to round 10. Gambia, has anyone been to Gambia? Yes? Do you know where Gambia is? It's a very interesting country, actually. It's like a snake. So you can actually run from one end to the other in a few hours. It's a small country, but Gambia benefited almost $80 million worth of investment in malaria. Almost 500,000 bed nets were distributed, insecticide-treated nets, for targeting the under 5 and pregnant women. With this, there has been integrated management of neonatal and childhood illness management, delivered through health workers. And you can see in terms of the deaths in the proportion of confirmed malaria cases in the health facilities, there's been a massive decline. And I was in the Gambia in January, and there's hardly any malaria in most of the health centers that we've visited. So this is a real success story. A real success story is Ethiopia, where almost $1 billion of investment has been made through the Global Fund by the end of 2011. And through this, and this is one of the real innovations, in the absence of doctors, where it would have actually taken years and years to create a cadre of doctors to work in the country, Ethiopia made a very wise choice to train health extension workers. These are workers that deliver, as both speakers have said, a core set of clinical interventions and public health interventions. And you have a pair working in villages called kebeles, each of which actually, and these kebeles have health centers, again, built through Global Fund financing, but also through funding that came from the World Bank and PEPFAR. And over 30,000 health extension workers have been trained and deployed within 5 years. That's quite remarkable. That's an innovation in being able to roll out a standardized curriculum and in a very careful way roll out a program. And I'm not going to go into detail, but in all the health indicators, there's substantial improvement. And there's been a DHS done recently, which shows further declines in these indicators. So big gains in relation to immunization coverage, decline in unoccupied mortality, TB, so on and so forth. And there are about 200,000 people receiving antiretroviral treatment. Similar story in Malawi, which is one of the poorest countries in Africa, which has benefited almost $200 million of investment from the Global Fund, utilized to deploy 10,000 health surveillance assistants. These health surveillance assistants do more than what a health extension worker does. They provide HIV, TB, and malaria services. They also provide disease surveillance, critically important. So public health and clinical medicine is fully integrated. There's supervision of traditional birth attendance, family planning advice, community-based maternal and newborn care, and there are a few other activities which I didn't show you. If I can convince you, I know I'm not claiming causality here, but you can see actually an increase in the health surveillance assistance. This is the orange line, and you can see a decline in the under 5 mortality. Now, I want to focus on 2 case studies, and both were actually cases in this slide that Nigel showed from the McKinsey work. One is the Narayana Hrudayalaya Hospital. This is the Institute of Cardiac Sciences in Bangalore, and the other one is Aravind, both from India. I'm showing you examples. There are lots and lots of small examples of projects, or 20 health centers, or a couple of hospitals, or a couple of processes. Both examples I'm going to show you are institutionalized, they've been scaled up, and they've been replicated in multiple settings. So these are actually working. They're not just projects. I think the literature is littered with small projects of healthcare improvement, of innovation, but these are sustained and established innovations. This cardiac center in Bangalore has 1,000 beds. They have 26 operating theaters, and they do 25 heart surgeries per day, 30% of which are pediatric, and they have capacity, which they're gradually building up to, is to do 70 heart surgeries a day. But just in 2004, they did almost 4,000 coronary artery bypass grafts. This is equal to the Cleveland Clinic, Mayo Clinic, and Mass General Hospital in Boston. These are the leading institutions in the US. And since 2001, this hospital has performed 50,000 heart surgeries. The complications rates are on par with the best hospitals globally. They employ a very interesting tiered pricing model. And this is social responsibility. So they have a number of adults that pay $2,400 per procedure on average. The break-even is $2,000, so 63% is at that level. Then you have a low-income group that are charged the break-even cost, and almost 1 in 5 of the attendants are actually paying less than the cost incurred by the hospital. So funding is utilized to provide care for those who cannot afford it, and 1% of the poorest do not pay anything at all. It's a very interesting way of generating revenue, investing back into the institution, but also increasing access to those who can not or would otherwise not be able to afford care. And in addition to expanding to about 9 hospitals in India, this institution is expanding overseas to Cayman Islands. Why Cayman Islands? Well, I knew you would say that, actually. That might be the reason, but Cayman Islands is very close to the US. So they're going to provide cardiac care to US patients, because the cost of, if they can manage $2,500, $2,400, that's about 1/3 or 1/4 of what it would cost in an average US hospital, and they have excellent outcomes. They also have the largest telecardiology network globally. It's quite remarkable. Other one is Aravind Eye Care System. I think many of you would have heard about this quite remarkable initiative, a big institution now. Just looking at 2010-2011 financial year figures, and this is available on their website, the numbers are really quite remarkable. In terms of outpatients, they had 1,380,000 paying patients and 406,000 free. They also have outreach to the community. Again, this is a very interesting innovation because, as Sir Eldred said, it's very difficult for poor patients to come. Sometimes you have to walk 4 days, 5 days, or a week to go to a hospital only to wait for a day. Then you're told, oh, you need to come back in 6 weeks' time. Patients just cannot do that. So Aravind Eye Care System, they have outreach clinics and they have camps. So they actually go to the patients. So almost 1 million outreach patients, 155,000 cataract surgeries on paying patients, and 84,000 free cataract surgeries provided. In addition, almost 80,000 cataract surgeries provided actually in camps. Now, what's so special about Aravind is that this is a very high-tech procedure, and Nigel talked about the production facility they've set up to produce their own lenses at almost 1/10 the cost of what is being produced elsewhere, but at the same quality. They're focused on continuous innovation, and they do this with process. They have an integrated process, a care pathway, an end-to-end solution that go all the way from eye camps, reaching out to patients, to actually discharging the patient. So you have the whole value chain covered. Secondly, they continuously innovate on the products, which now they produce themselves, the lenses, the sutures, the eye drops, everything that is needed is produced at source. They also have eye banks. So for retinal surgery, so on and so forth. So they've become an integrated organization. Well, they've integrated sort of backwards, producing the materials that they need to undertake the surgery. They also innovate on procedures, very, very sophisticated. They use time and motion studies to ensure that the key asset that they have, and that is, or the key assets, that is the surgeon and the nurse doing procedures, their times are used very, very effectively and very efficiently. And they have excellent innovation around people management. They stratify patients, and different healthcare providers deal with them separately, and they have very careful selection of staff who are retained, unlike many other settings where people are trained and they end up elsewhere. So innovation is not ad hoc. It's on the process, the product, the procedures, and people. And they have a total quality management initiative underpinned by systems. So they benchmark performance of each department on quality, service, cost, staff retention, academic activities, so balanced scorecard. And there are weekly team meetings where these are shared, real time, with the team to discuss results and agree actions. And there are quarterly reviews with heads of department and with the chief medical officer of each of the hospitals. They have web-based cataract surgical outcome benchmarking and the monitoring tool, and they use web-based hybrid learning platform for the stuff. So really quite a remarkable setup. So what can we learn from these two examples? So what's a typical, or what are the characteristics of the Aravind and the cardiac center? What have they focused on? I'm still a working professor, so you're not going to get away without questions. So let's go to the side.
So the hospital streamlined their procedure, didn't they?
Yes.
And the Aravind is similar, but they looked at innovations at every step.
Yep, so they have continuous innovation at every step, yes, that's true. But in terms of the procedures that they've chosen,
very specialized.
very specialized. Good. Anything else?
They're focused on transparency and equity.
Yeah, I think that's a real innovation. They utilize funds to pay for the poorer segments of the society. But in terms of the delivery, so they focus highly specialized. What else? Also quality. But how do you achieve quality? What do you need to do? The standardization. Excellent. Because we talk about quality as if it was a loaf of bread. Nigel will tell you, quality is actually very difficult to define and very difficult to measure, especially if you want to continuously improve. So what these hospitals have done is that, or these institutions, they look for opportunity for continuous learning, for learning curve gains and quality improvement. I'll explain that. So the procedures they've chosen are replicable, cataract, yes, in one hospital and another hospital. So you can replicate the same model elsewhere, and you can scale up. You can do 1, 10, 200, 500. They're doing 155,000 cataract operations. Right? It's quite remarkable. Typically, an eye surgeon in the UK, they do about 200 cataract surgeries a year. In Aravind, they do about 2,000, probably more. So characteristic, they've selected a segment. So they've segmented the care provision. They said, we're going to focus on a segment that is where the service is replicable and scalable. What this enables you to do is to get beyond the scale economies, you get learning curve gains. Because you do something more and more, you become an expert at it. So your cost goes down. Quite remarkable. So you can do more with the same price. They're also dealing with conditions that are that provide the opportunity for standardization in terms of diagnosis, also in terms of treatment. So they have diagnostic certainty. Cataract is pretty straightforward to diagnose, and they have the tools. They've perfected that. They've standardized the diagnosis. They stratify patients. Patients come in, you have the triage. Patient A, B, C, they follow different paths. And then you know which treatment each of these patients are going to have, as opposed to somebody presenting with fever in Africa. You know, this could be one of many, many things. So they've selected very carefully the area that they want to focus on, and they've managed to achieve real excellence and continuous quality improvement because they've standardized procedures, they focused on the whole care process, and then they're able to measure each and every step, what happens, and continuously improve the outcomes in relation to those. So very important lessons in terms of quality improvement, in that the first lesson is that you need to stratify your patient groups. Secondly, choose interventions that are very clearly defined and think about the whole care pathway. And thirdly, just go for relentless improvement across every single activity along this care pathway that is being targeted by the team, and use different professionals for different aspects. So I think we have a lot to learn from these institutions in the UK and beyond. So thank you for your attention.